Hi, my name is Teresa Wick. We're going to do a quick presentation on DKA, or diabetic ketoacidosis. This entire presentation is geared towards the clinical nurse, the critical care nurse that's already taking care of these patients in the ICU area or the ER. And it's just a quick overview to help us remember what it is that we are dealing with and the underlying causes of the disease process. We're going to talk a little bit about diabetes, but we're really going to nail what it is we're looking for insulin and why it is so important to make sure we talk about what's your glucose, what's your blood sugar, and we very rarely talk about insulin, and we need to understand that what we really need to know, if there was a way to do a test, would be what is your insulin level, because this is what's really important. Insulin is what is going to help break down our food and help at the bottom level of changing everything that we eat into energy for our body. And without it, we can't store energy, we can't use energy, and of course without energy we can't survive. So we're going to talk about insulin really well. There is going to be a 12-question quiz at the end of the presentation. That is designed to make sure that you walk away with the knowledge that we need to have before we roll out our new protocol for treating DKA. It's called the 2-bag method. We'll kind of touch on that briefly. We're not rolling it out quite yet. We want to just have a brief reminder of what the disease process is first. There will be a bingo game at the end of the lecture where we're going to ask some questions. We'll incorporate classroom questions into the review for the quiz, and we'll play bingo. So when the right terminology is used, you'll get to mark your squares, and there is a Starbucks gift card for the winner. One of the things in your packet that you'll be taking with you today is the algorithm for the new DKA protocol, our 2-bag method. It's replacing our 4 pages that are stapled together plus your cheat sheet on the back to do your math. There's no math, it's done for you. It's 1 page. It is so nurse friendly. It's patient friendly. It is so much safer. You are not having to worry about doing math. You're not having to worry about making sure that you are readjusting that insulin pump correctly. It's very, very user friendly, so we'll touch on that in just a second. So we all know what diabetes is. We have patients that are diabetic all the time. We teach our patients how to take care of themselves. Sometimes it works, and sometimes we feel like we're saying the same thing over and over again. So we have our type 1 diabetic, is the diabetic who does not make any insulin at all. They are completely dependent on putting insulin into the body, usually in the form of injections, daily, at the same time, every day, same amount, over and over, and that cannot be deviated from, and if they do deviate from it, then there's issues. Type 2 diabetes, you're making insulin, but your body is not able to take that insulin and make it work like it's supposed to. It's kind of like the insulin's a little sluggish. And so you're going to take PO medications to help boost your insulin you're already making in order for the insulin to work and do the job that it is designed to do. So what's really, really important is to understand that without insulin, we have no energy. Without energy, we have no life. So insulin is super important. It is originally produced in the pancreas, and just like everything else in our body, it knows when it needs to make it, when it needs to put it into the blood system, and it's there for when we are done eating. It secretes insulin. That insulin takes the glucose that's found in the food that we eat, uses it, helps break it down into the smaller molecules to be used for energy. Leftovers that we don't need at this particular point in time are then converted into glycogen and are stored in the liver for later, like in between meals, or if we decide we're going to run a marathon. By we, I mean anybody other than me. I don't do that. So you've got that energy there for you. And if we were to accidentally maybe have 1 too many slices of pizza or 1 too many pieces of cake and not get up and move around so much, it also helps store the excess carbohydrates that we eat as lipids in our adipose tissue, otherwise fat, which can also be used for energy later on should we run out of food or not be able to eat on a regular basis, that kind of thing. So it plays a very important part in putting things in little compartments where we need it, and then helping us use it when the time comes. So without insulin, all of what the body does with insulin reverses. So if you run out of insulin, the stored glycogen in the liver pours out into your blood system, and in fact becomes more sugar. Those stored lipids cannot be stored appropriately. They come back into the blood system as fat. And so we have a lot of different comorbidities happening inside our body that we need to look for. One of those things is that when we quit using glucose and we start using our stored fat as energy, it increases the lipid level in the blood. So we now have to look for DVTs, PEs, MIs, CVAs. We can have the same kind of issue with clotting and clots, especially the more lipids that are put into the body. And this happens as the DKA progresses, the more everything is spilled back into the blood. So our brain starts swimming in syrup because there's way too much glucose. There's no insulin to break that glucose down into energy, so we cannot use it. So the body's throwing fat in, thinking we can use this fat as energy. We can't use nearly as much of it as is being put back into the system. And we still don't have all of the components in place to do all that correctly as well. So these patients come in, they're super sick, they're weak, they're tired, they're thirsty. In the beginning stages, they're going to tell you they're super thirsty. They've been drinking water all day long. They've been going to the bathroom nonstop. Some of them will tell you they had to stop 6 or 7 times just coming to the hospital to go to the bathroom. Nausea, vomiting, some tachycardia. They're breathing, they're tachypneic, they're going to be breathing more than maybe usually within 24, 26, 27 breaths or higher. The longer this process has been going on, the more ketones they're trying to breathe out. When that happens, you get that fruity smelling breath. And so they sometimes are even mistaken as being drunk because they're confused and altered. They have fruity smelling wine smelling breath, and so it progresses into not being a pleasant day for them. Anyway, so you got to keep in mind what these patients present with, and they can also develop this into the hospital. You know, we can get a patient upstairs who's being presented or being admitted for one thing and develop DKA in the process. A lot of those patients are going to be your sepsis patients or your patients that already have a sign of an infection, because infection plays havoc on these bodies of a person that has diabetes and makes it very hard for the blood sugar and everything else to stay in control. The important things to remember is that DKA and hyperglycemia are not the same thing. That there is a big difference between having a high blood sugar, and then having your pH of your blood out of whack, having no insulin working at all, and having this cascade of effects happening in your body. So there are two totally different processes. One is treated with fluid and insulin. The other one is treated with admission to the ICU, treatment, fluids, electrolytes, large amounts of insulin, and constant monitoring until we get everything back into the correct amount of your potassium and your sodium and your sugar and your calcium and your magnesium and everything else that's gotten out of whack. The new protocol for our DKA is going to keep the insulin at one exact dose. You're going to set the pump at a single dose of it's going to be 0.1 units per kilogram per hour, and you're just going to leave it alone. The only time you'll ever adjust that is when the sugar drops back down to its normal level. Then you're going to cut it in half. You don't turn it off. You cut it in half. These people are not making insulin. They haven't had insulin in their body for a while. We've got to keep that insulin at a constant level so that it can kind of clean out all the stuff that's there and break down all the things that it needs to break down, and it helps store the stuff that we need stored and use the stuff we need used. So you're going to be just adjusting your normal saline with potassium already added and your D10 with normal saline and potassium added. So because the potassium is already in the fluids that we're replacing, we don't have to wait until the potassium shifts to something that we don't want it to. We're going to just go ahead and keep it at a somewhat constant level. We'll monitor those BMPs, but studies have shown that 90% of the time the potassium stays within the norm and you don't have to give any extra potassium. This method is actually how they've been treating children with DKA for quite some time. And it was used by the University of Michigan in Ann Arbor for about a 2-year study to prove that it is actually quite safe, actually safer than the current standard for treating DKA. And there'll be more education on that as we roll it out. We just wanted to make sure that everybody understood why we don't turn that insulin pump off when our sugar comes back down to a normal level. That seems to have been the big thing all along, is that we check the blood sugar, it's at 80. Everybody's like, oh, their blood sugar is normal, turn the insulin off. They don't have any insulin in their bodies. They're not making insulin. If we turn the insulin off and we wait for the doctor to come put in the orders for the sub-Q insulin, or to start the insulin protocols over here, meanwhile the sugar's back down, yes, but the insulin level's not where it's supposed to be. The agonal gap hasn't closed, and the electrolytes haven't been replaced appropriately. So we really haven't gotten out of DKA. We've just corrected one of the electrolytes. We've corrected the glucose, but we haven't corrected all the other stuff. So we don't want to be turning things off. We don't want to be stopping anything until we get labs that are consistent for 2 to 3 draws. The doctors are on board with all of this, and then of course we'll turn the stuff off at that point. So if it is at 80, you're just adjusting the D10 over here to keep it a little higher. If it's higher, excuse me so much. If it's higher, then you're going to just adjust the normal saline to bring it down a little lower, and it's a little box. You look at the number, you go across, that's what you do. It's great. It's very user-friendly. Almost too easy, which I think is going to be the problem. I think that's going to be one of the big questions, is how did we take something so complicated and make it so easy? And that I don't know the answer to. The other is going to be teaching our patients the importance of maintaining their insulin level, and maybe trying to do more education on what insulin does in the body rather than what is your blood sugar, have you been checking your blood sugar. I think we've taken diabetes and we've wrapped it all around this blood sugar, but we have failed to educate the public on all the other components that are necessary to keep that blood sugar where it needs to be, and the importance of making sure that we take the insulin like we're supposed to, or the PO medication like we're supposed to. I think another question too is going to be that there's a lot of new medications on the market, and a lot of us aren't aware of what they are anymore or how they're used. I have patients daily come into the ER that'll give a medication list that have like, what are we taking this for? I don't even know how to pronounce this. And they're like, oh, that's my new diabetes medicine. I take 2 pills in the morning and my insulin at lunch. So there is a lot of different changes out there on how endocrinologists are treating diabetes as well. So we just have to stay updated, journal reading, obviously, classes when we can get them. The ENA website has a great CE on DKA, hyperglycemia, diabetes. They're all in there, and they keep those pretty regular and pretty up to date. And as crazy as it is, the Mayo Clinic does a great job on their website explaining things as well. I don't think there's any other questions per se that I think are going to be difficult to understand in this presentation. I think for the most part it's just a quick reminder, and then just making sure that everybody's on the same playing field and everybody is at that same level of knowledge before we move forward into rolling out a new protocol. These classes are probably going to start happening more quickly and more on different topics. We realize now that having review classes on different pathophysiology really helps us stay connected to what we're doing and why we're doing it. It helps with the education part for the patient, and it helps with the nursing education as to why we're so vigilant on what we have to do. You can't replace potassium if the magnesium is low. So if the phosphorus are out of whack, if the calcium's not where it's supposed to be, you have to have one in order to have another, in order to have another. It's that cascade effect. So now we understand that you don't pick and choose which medications in the MAR to give. You give them all, and you do them in a sequence that are important to do. So I thank you for your time. At this point, we would go over classroom questions. We would actually go ahead and review for the quiz. And I was planning on doing this presentation in the hospital in a conference room, but the doctors bumped me, so I lost my conference room. So here we are in my dining room. But I have really learned a lot from this class. I thank you guys for your time, and I hope to get to meet you in person when I get to come to Arlington. Thank you so much. Have a great holiday.